Welcome to the AVA Academy. Hi there. I'm Judy Thompson, the Director of Clinical Education at the Association for Vascular Access. Today we're going to talk about the vasculature of the upper arm. So, little orientation to what we're looking at. Left arm, starting up at the humerus, coming down, we have the ulna and the radius. Remember, in the anatomical position, the radius radiates outward in the anatomical position. Palmar side up, dorsal side, it would be to the back. So arteries in this model, like many models, are red. The venous system is in blue. Distally, we have phalanges, carpals, metacarpals. Then, I'm going to use this for a pointer. We all know what that is. Here we have the ulna, and we have the radius. This bone right here is the radius. Remember, in the anatomical position, it comes out, it radiates to the outside. Radius, ulna, greater tubercle, humerus, and a cubital fossa through here on their body. You feel a little notch, and right above that, the surgical neck, is the greater tubercle where an interosseous device would go. We have our wrist, our metacarpals, carpals. We're not going to talk too much about these bones because why? We don't want you to put an IV in those. Moving on, onward and upward. Let's go to the arterial system. That's that send it out team for oxygenation. This system delivers oxygen-rich blood from the heart to the body, and we use the arterial system for the insertion of A-lines. Let's start from the top, and then we'll move on down. Number one is our axillary artery. Axillary artery is number one. Number two is our humeral circumflex artery. Our axillary artery feeds to the brachial artery. Brachial artery is number three. Number four, this is our deep brachial artery. Deep brachial artery. Number five is our superior ulnar collateral artery, and it comes around to the ulna. Brachial artery comes down to the antecubital crease. So let's look at that in detail. So number three is our brachial artery. We've talked about that. So let's pull these up. Remember, we said this is our brachial, number three. As it comes down, it's going to split and feed towards the ulnar side. That would be the ulnar artery here. And again, it will split and come down to number eight, which number eight is the radial artery. So down to number nine, the ulnar artery, down towards number eight is the radial artery. Got that? Awesome. Those are the big deals in arteries when we talk about the vasculature we need to know for vascular access procedures. So what's really important about the radial and the ulnar artery? The radial artery is our preferred site for adults for A-lines in most situations. Sepsis is a situation where it's not, but most situations, this is our go-to site. The ulnar artery, this is the ones that we use as we hold pressure when we're doing an Ellen's test. So holding pressure, they have a clenched fist, they let go, we release pressure, and the hand pinkens up, hopefully, within 10 seconds. But another video, another day. Radial artery, ulnar artery, coming back up, they come in and they form the brachial artery, which feeds into our brachial artery, and it feeds into our axillary artery. Now we want to go back a little bit and talk about the layers of these vessels. As we mentioned earlier, arteries take blood away from the heart to the tissues of the body. The veins return the blood back to the heart. The arterial system is a high-pressure system, while veins are a low-pressure system. Our peripheral veins have valves to prevent backflow of blood, and the arteries do not. Arteries and veins are similar in the fact they both have 3 vessel layers. The tunica adventitia is the outermost layer. It's comprised of connective tissue, collagen, and elastic fibers that surround and support the body of the vessel. The tunica media is the middle layer. It has nerve fibers that are responsible for dilation, constriction, and parasympathetic responses. And lastly, the tunica intima is the innermost layer. It's made up of smooth endothelial cells that allow free flow of cells and platelets. It's also responsible for the initiation of that clotting cascade. So what's the difference between these structures, the structure of an artery and a vein? Well, the arteries have very thick walls to withstand that high pressure, and the veins have thinner walls. Arteries are exposed to the highest pressures of any vessels. They have a thicker tunica media. Elastin allows them to stretch and recoil, and the smooth muscle allows them to constrict and dilate. Veins experience lower pressures. Their walls are thinner than arterial walls, and their lumens are larger, allowing them to accommodate a larger volume of blood. The tunica adventitia is the heaviest wall layer in veins. Veins also have valves. These valves are most abundant in the veins of the limbs, where the upward flow of blood is opposed by gravity. Understanding the basics of the vascular anatomy and how each layer impacts your vascular procedures is crucial for safe practice. We've discussed the skeletal system, the arterial system, and also the structure of our vessels. Now we're going to get right into the venous system. We have all seen that proud nurse that has placed a PIV in the thumb. We're not going to cover the veins of the thumb, veins of the fingers. Why, you ask? Because we don't want you to place an IV there. Moving right along. There are situations where the dorsum of the hand will be appropriate for some of your patients. These are the metacarpal bones. These are the dorsal metacarpal veins. Makes sense, right? Now, as these come up, they will branch one direction or the other. And they also do a little communication here. Remember, as we spoke before, the pinky side is the basilic side. The thumb side radiates outward to the outside cephalic vein. So as this branches out, comes up and branches, this is going towards our cephalic vein. This is going to wrap around to our basilic vein. So now let's flip this over and look a little bit further into this region. I'm going to turn it so you can see the numbers better and hopefully get a very good image for you. That's number 17, which is our basilic vein. Number 17 is basilic. Thumb side. Thumb side is radiates outward, and that will correspond with number 19. Number 19 is our cephalic vein. There's a lot of other goodness in between that we will see. Knowing that we want our PIVs to last as long as possible, we know that this area in the forearm has been shown to have increased dwell time. Number 16, easiest way to call that is a median vein. There are we have the median antebrachial vein. You can call it the median antebrachial cephalic vein. Let's just say these are our median veins. Let's go a little further. We still have a couple more vessels to identify. Number 8. Number 8 we already said is next to the radius. We have a radial artery. Radial artery is number 8. Along with that, it's paired with the radial veins. Radial veins, 1 and 2. Ulnar artery, number 9, paired with ulnar veins. Perfect. Let's follow these guys up because there's interesting stuff up here. As we follow number 9, we have the ulnar veins coming up, and they join here. They're going to join into the brachial vein. The brachial vein. Similarly, on the radial side, number 8 comes up, and it's tough to see. Let's pull some of these vessels aside. But it joins and makes the lateral vein, the lateral brachial vein. So right through there. So our radial and ulnar veins come together and make our brachial veins. Brachial artery, brachial veins. All these other goodness here. We've got 17. It's our basilic vein coming up and making the large basilic, but it's also joined by number 16, our median veins. Let's just call it median veins. So let's follow these and find out where they go and what they become. Cephalic vein coming up, it's joined or anastomosed into 21. 21 is the accessory cephalic vein. So it comes and continues upward into number 20, which is still the cephalic vein, but 19 is the cephalic vein. As it passes and it goes to 21 to the accessory cephalic, it also goes directly and communicates to the basilic vein. So cephalic goes both to the cephalic, accessory cephalic, and then back to the cephalic, but it also travels to the basilic vein. The basilic vein is also joined by all the flow from the basilic and the median veins. So that joins to become the basilic vein. As we come up into the AC, we form this nice V right here, which is loved for venipuncture, and also some of our friends in the ER like this area too. So working on that part. Our brachial veins, right next to the brachial artery, number 6, our brachial veins, are formed from our ulnar and our radial veins. Our ulnar vein, ulnar artery, ulnar vein, comes up, and in this region, see if I can pull these aside enough. Let's move that artery out of the way a little bit. Don't you wish you could do that during procedures? Just scooch the artery out of your way. There we go. Now you can actually see. So these are the ulnar veins. Ulnar vein, ulnar vein. As it comes up, they join to create the medial brachial vein right here. Medial brachial vein right there as it joins. Guess what veins come together to join the lateral brachial vein? You guessed it, it's the radial. So let's see if we can find them. A little bit tougher to move all these veins around, but oh, there we go. I found it. Wouldn't you love it though, seriously, to be able to move the arteries out of your way? Okay, we have our radial artery, radial veins. And as they come up, you're going to see they're joining, coming up, joining right here. They come together to join and create that brachial. Can you see? I want you to see. They join and create the lateral aspect. So there's 2 brachial veins. It's going to be the one that radiates outward. So laterally. Lateral coming from the radial veins, medial coming from the ulnar veins. Pretty cool, right? I think so. Our brachial vein coming up. We have the basilic coming up, and then we also have our cephalic still coming up. Now, as we see it, let me make sure I turn this so you can see the numbers clearly. This is our cephalic. And this is showing how it flows into the axillary vein, which is true, it does. But we all know that sometimes the vessel right around here looks large, plump, perfect to use. But as we try to turn this corner, it narrows, often right through here, but also not shown clearly on this model, but it also makes a little hook into the axillary vein, making it really tough to thread at times. So just know that it dumps right into the axillary vein, and oftentimes that real tough hook makes it hard to thread your catheter all the way through. Now, our brachial veins, brachial, and basilic vein join and become the brachial vein, which flows into our axillary vein. That's it for the skeletal system, the arterial system, and the venous system. Now let's start talking about nerves. A thorough understanding of nerves of the upper extremity is so vitally important when it comes to vascular access procedures and safe, comfortable procedures for our patients. Let's finish this up strong. We're going to talk about the nerves of the upper extremities. This is such an important topic. The nerves we're going to cover are the median nerve, the ulnar nerve, and the radial nerve. We're going to discuss the sensory pathways, which will give you an understanding of the signs and symptoms of a nerve injury. Now, the obvious bite of a needle in direct contact with the nerve, well, that doesn't need a whole lot of explanation, but we're going to get into some of the subtle differences between having an arm extended outward and the circulation is slowed for a little bit so the arm goes numb versus a digit being numb. One of the many reasons that AVA does promote no blind sticks is the ability to visualize nerves prior to putting a needle near it. Anytime you're placing a device in the upper extremity above the AC, ultrasound is mandatory, and the nerves that you need to identify prior to puncturing are the median nerve and the ulnar nerve. The median nerve runs directly with the brachial artery and veins. The ulnar nerve in the upper arm runs deep to the basilic vein. As the median nerve comes down, it'll come down the radial side, which will innervate the radial nerve. Remember we said that the ulnar nerve lies deep to the basilic vein. It also travels down distally to the digits. Remains with the same name, ulnar nerve. And you guessed it, it's on the pinky side, along with the ulna bone. Nerve injuries can become evident during the insertion process of placing a needle and/or a sheath dilator into the tissue. And they can also show up post-insertion if a patient complains of numbness or tingling and didn't have that identifiable jolt or electric shock feeling in their hand during the insertion of a device or just the placement of a needle. Those are the ones we have to be particularly vigilant with and pay close attention. These conditions can be devastating and become chronic conditions. The patient suffers, the clinician suffers, and the hospital can suffer, as these complications are largely preventable and often end up in a court of law. Let's get into some of those specifics on how to identify the difference between an arm that has been out for a period of time with a tourniquet on it and the circulation is slowed and they feel numb versus the nerve has been impinged or damaged and they're losing sensation. The patient may complain of numbness or tingling. If you've been in your procedure for a bit of time and the arm and hand have been at or below the level of the heart, it may be just that the circulation was slowed. And a couple of fist pumps and movement, the hand should come right back to normal. That's a watch and see. That's something that you want to look at, check back in 5-10 minutes, see if the numbness has completely resolved. And then you can pretty much chalk that up to procedural just numbness. When a patient complains of numbness and or tingling, that is a situation that you never want to ignore. And you need to document that. Document what those signs and symptoms were, the actions you've taken, who you discussed the problem with, and what your follow-up plan is. Check back frequently until that is resolved or you have taken action. Having a patient complain of their entire hand being numb, my first thought would be a wait and see. Follow that for 10 to 30 minutes. And if you find complete resolution of the symptoms, it's likely that it was procedural. However, if they complain of numbness in digits in either their pinky ring or their thumb, their index, or their middle finger, or any combination of that, then you need to think specifically about a nerve impingement, a nerve irritation, something with the nerve is going on. That can never be ignored. It must be addressed, and the line has to come out. If you leave a line in and a patient is complaining of numbness, tingling, electrical, any of the above, the liability is on you. So be mindful of that. Be vigilant with it. This causes devastating outcomes if it's ignored. This image has been up for a little bit. We're going to get into the specifics of nerve and sensation. Let's start with the median nerve, the palmar aspect of the hand, and the inner aspect of the thumb, as well as the index and middle finger upper digits are innervated by the median nerve. So let's put this into a practical situation. You are putting a pick in to the brachial vein, and post-procedure, your patient complains of numbness in her index and middle finger. That would be a real big red flag for you to say, my patient's hand is not numb through and through. I have digit numbness or digit that I'm tingling. Pull the line. Catheter is likely laying near or on a offshoot of that nerve. Those symptoms can wax and wane as they move their arm position, their hand position. It could change, and all of a sudden the numbness goes away, then it comes back, goes away, comes back. What we don't want to do is create permanent nerve damage for that patient. Moving on to the radial nerve. The radial nerve is depicted in blue. So it has the dorsum of the thumb, the index finger, and half of the middle finger up to the most distal joint. The ulnar nerve. The ulnar nerve has responsibility for the medial aspect of the hand. Again, we're talking in the anatomical position. The medial aspect, and that's shown in orange. I think it's orange. But also I want you to take a peek really close. If you look at just the underside of the thumb, it also innervates that section right there. So pay close attention. If your patients are talking about numbness, tingling in certain parts of their hand, you need to be highly suspicious of that catheter bothering a nerve and take action. Swift, decisive. I hope this has been helpful. I appreciate any comments you might have on this. Look forward to our next video on anatomy and physiology and other procedures with vascular access. Thanks for tuning in, and come back often to the AVA Academy.